All right. Let me start my... Okay, you can see the slide now, is it not? Immunology of immunization. We will be today talking about mainly about immunization in the immunocompromised. And as we go into a next, we will talk about that. See, there are special situations. Immunization in immunocompromised, preterm babies. Then when you are sick, what do you do, etc. That's what we will be discussing today. Hopefully, we will finish the 64 slides. Ashwini, can you read it?
Immunization in the immunocompromised. The immunocompromised are in the greater need for vaccines as they are more susceptible to infections. But at the same time, the immunogenicity or the efficacy is lower and the risk of adverse effects with live vaccines is higher. However, vaccination in an immunocompromised child is safer than often perceived.
Therefore, it is more necessary but less effective. Therefore, we have to give. Therefore, it may not be that effective. Therefore, it's in a very, the children require it more than the normal children, but they may not respond. Now, every sentence of it, this line, general principles of vaccination of the immunocompromised have to be read. Okay, read it from the beginning, not only the highlighted one.
Okay, sir. All inactivated vaccines can be given, but immunogenicity and efficacy may be lower. In severe immunodeficiency, all live vaccines are contraindicated. In mild or moderate immunodeficiency, live vaccines may be given if benefit outweigh the risk. Patients administered live vaccines inadvertently prior to diagnosis of immunodeficiency should be watched for vaccine-related adverse effects. Ideally, antibody titers should be checked post-immunization on a regular basis, and the regular boosters may be administered if needed. Higher doses and or greater number of doses should be given if indicated, like in hepatitis B. For major or contaminated wounds, tetanus immunoglobulin IG is required in addition to tetanus toxoid, even if 3 or more doses of TT have been received in the past. Household contacts of the immunocompromised should not receive transmissible vaccines such as oral polio vaccine, but can safely receive other non-transmissible live vaccines such as measles, mumps, rubella, and varicella. All household contacts should be fully immunized, including varicella or influenza, to reduce the risk of transmission to the immunocompromised. After administration of oral rotaviral vaccine, strict hand hygiene should be observed by all caregivers for a week after administration.
Now, all these, you can get a short note or you can get an even an essay on general principle on immunocompromised immunization. All the points which are mentioned here are very important. Now, what I want to note to you, it will come up again later on also. This from the Indian Academy of Pediatric Immunization. The household contacts of immunocompromised should not receive transmissible vaccines such as oral polio also, but can receive MMR and varicella. Therefore, when there is a pulse polio campaign, it's very important that you don't give oral polio to children whom in their relatives they are on dialysis, severe diabetes, or on cancer treatment, or on high dose steroid for some reason or the other. Remember this is given in the Purple Book of Immunization, and this is not followed because whenever there is a pulse polio campaign, the idea is to cover as much as possible. Nobody asks any questions. They want to put it down, shower it down the mouth of the poor child without asking any question. But definitely as a pediatrician, whenever the patient is taking oral polio, ask anybody else in the house as anyhow. Have you ever seen any pediatrician ask this question? Anybody at home? See, we are giving IPV and OPV for our immunization, regular immunization also. The addition of OPV is actually questionable because IPV protects almost 100%. Why give oral polio along with that? That is because it's a national program. But if somebody else in the house is on dialysis, severe diabetes, or on cancer treatment. You need not give that oral polio. Remember this. Okay, read it.
Vaccines including pneumococcal, varicella, depending on degree of immunocompromise, hepatitis A, and inactivated influenza vaccines should be given. Although there are no guidelines regarding rotavirus vaccines in the immunocompromised, except in severe combined immunodeficiency, there have been no safety concern when administered to HIV-infected subjects.
Okay, now I'm just going very fast because most of this is taken from the Indian Academy of Pediatrics book also. And remember here, they make a statement that what you call as uh, varicella, depending on the degree of immunocompromise. You see, it's very important to give varicella vaccine for immunocompromised patients because varicella can be very severe when the patient is on chemotherapy and others. Therefore, you have to judge it. How to judge it is a difficult question. Regarding rotavirus, one end they say you should wash your hands, etc. But better to give, though there are no safety concern. Now, this from the IAP. If you look at vaccine recommended for children, adults, and underlying conditions, you can't read the whole thing. See what you look on the left side here. What you look here, all these vaccines are available. I think meningococcal B is not available, hip, HPV, tetanus. Therefore, in special conditions, if you miss giving it, what will happen is when the child develops a problem, you can be in serious problem. Okay. Therefore, you must understand this. I have given some highlight only. Cerebrospinal fluid leak. This happens, some children have very rarely, I've seen only one patient have a leak through the nose. Child will come to you with rhinorrhea and you think it is rhinorrhea. But later on, when you assess if you have a doubt, you measure, you look at it will have proteins and sugar equivalent to a CSF. That's why, and they get recurrent meningitis. Therefore, there the pneumococcal vaccine is a must. The most important you should not miss is a cochlear implant. You see, cochlear implant is a very costly business, very high tech business. The patient undergoes a serious surgery, and then if he develops an infection, the cochlea that will fail. Therefore, remember, of course, our ENT surgeons are quite aware of it, but remember to make sure that every patient who comes to you with cochlear implant, this is a major thing because basically before there was no treatment for nerve deafness, only conductive deafness they could treat. Now they could treat with cochlear implant. Therefore, all this, the rest you will know. And remember that there are certain indicators for meningococcal, quadrivalent meningococcal, conjugate meningococcal vaccine. There, don't forget it. Asplenia is one of them. And we have the meningococcal vaccine. Don't forget it. I don't think we have meningococcal B vaccine because among the quadrivalent vaccine, A, C, W, and X, AC, the B is not there. B is available, to my best of my knowledge, only in UK. Hip vaccine. But you may be wondering why exactly we are talking of hip here, because we are regularly giving it. But the issue you should understand is nobody is given a hip vaccine above 5 years. Therefore, if you're having a splenectomy, if you're having a patient with bone marrow transplant, you will have to look into the indication to give these vaccines also. The others are rest, of course, tetanus and all, even immunocompromised, we have a different type of indication. Now we come to HIV. HIV is the commonest thing. You can read through it. Yeah. Yes, Ashwati.
The slide didn't change.
Now it will change. Don't worry. It changed.
No, sir. Vaccination is usually safe and effective early in infancy before HIV infections causes severe immune suppression. The duration of protection may be compromised as there is impairment of memory response with immune attrition. In older
I can't hear
In
you.
older HIV-infected children and adults, the immune response to primary immunization may be less, but protective immunity to vaccine received prior to the infection is usually maintained. However, immunity to measles, tetanus, and hepatitis B once faster than other
Waves
antigens.
faster than other antigen. Please read louder because it's getting recorded. Otherwise, our recorded video may not be that good. Now, remember, the moment there are certain things which you had to act fast. You diagnose a nephrotic syndrome, the first thing you think of is you can delay the steroids for 10 or 14 days to make sure that the immunization is complete, especially pneumococci. And if the patient is not immunized, to complete the immunization. The immunization, the thing of splenectomy for any patient, think of immediate immunization. Similarly, HIV, unfortunately diagnosed in infancy, newborn, when you think of antiretroviral therapy and other things, as a pediatrician, the first thing you should say is, let's give the child the vaccination. Because at diagnosis, newborn, infancy, the child is unlikely to have severe immunosuppression. That's something which should, therefore, early on you should give. Okay, can you read it?
In progress.
Has it changed?
That's
Yes, read it
no,
loudly.
sir. Not changed, sir.
Okay, I'll start reading.
Now
When it
changed.
change,
The,
okay. The
the
efficacy and
efficacy
safety
and
of
safety of
yeah, read it. Okay.
vaccines depends on the degree of immune deficiency. Generally, a cluster of differentiation 4 plus, that is CD4 plus, count less than 200 cells per millimeter cube, or less than 50 percentage is known to elicit a minimal or no host response, even if there is a better antibody response, such as antibody response may wane at a faster rate in HIV-infected person. Antiretroviral therapy can improve immune response to vaccine, but not to the level of an uninfected subject. Live viral and bacterial vaccine pose an enhanced risk for uncontrolled replication of the vaccine strain.
Therefore, actually I was a little surprised because they have organized it based on the symptomatic or asymptomatic. Anyway, can you read it now? It does not change for you. I'll start reading. When it changes, you read. The Indian Academy of Pediatrics, World Health Organization, American Academy of Pediatrics, Advisory Committee on Immunization Practices, and Center for Disease Control recommend all live vaccine in asymptomatic HIV infected children except OPV. Remember this, OPV they are very concerned about oral polio vaccine. Therefore, how do you give a vaccination in human HIV? Symptomatic, asymptomatic. Asymptomatic, all live vaccine is a problem. Killed vaccine, no problem. Now, has the slide changed for you? Yeah.
Yes, sir.
Read it
However,
loudly.
in symptomatic child,
Yeah.
all live vaccines are forbidden. But at times, measles, MMR, varicella vaccine may be considered on individual merit. Yellow fever vaccine is contraindicated in symptomatic but can be given in asymptomatic and those at risk of exposure. For killed vaccine in an HIV infected children, ideally post vaccination monitoring of a seroconversion is desirable. In an HIV infected child, there is a multifold enhanced risk of disease such as tuberculosis, hepatitis A and B, measles, influenza, varicella, pneumococcal, and meningococcal disease. Hence, in such situation, a judicious and intelligent decision of the physician is warranted.
See, there is no contraindication to kill the vaccine actually, but it may not be that effective. Therefore, you should normally give it. Live vaccine, there is a problem if it is completely immunosuppressed. We have gone into it. Now, actually, the Indian Academy of Pediatrics, there is a table which will come up soon. Therefore, it's basically based on asymptomatic and symptomatic. And therefore, I think you must know about each one of them. I think this table summarizes the whole thing better than anything else. Gopika, can you read it? You are at home. Gopika is not there.
Sir,
Lasima, can you read it?
yes, sir.
Yeah.
Uh,
You read the whole
vaccine,
thing. It's very important.
BCG,
Yeah.
asymptomatic
One
at
minute,
birth.
Lasima. The headline: Indian Academy of Pediatric recommendation for immunization HIV infected children. Okay. And now that is mainly based on asymptomatic and symptomatic. Each vaccine
In
you should give. Okay.
In asymptomatic patients, BCG, DTP, polio vaccine.
No, you start telling BCG, asymptomatic.
BCG in asymptomatic, yes at birth. Symptomatic, not recommended. DTP, DTAP, TT, as per the routine schedule, 6, 10, 14 weeks, 18 months, and 5 years.
Symptomatic
Polio
or
vaccine.
asymptomatic, you can give killed vaccine. Okay. Okay, go ahead.
Similarly, in polio vaccine, both asymptomatic and symptomatic, IPV at 6, 10, 14, 12 to 18 months, and 5 years. If indicated, IPV to household contacts also. If IPV is not affordable, OPV should be given in asymptomatic subjects.
Remember this very important. This is a very medical
MMR,
legal
yes.
issue. Hold on, Lasima. This is very important medical legally because the Indian Academy of Pediatrics recommends if IPV is not available to give OPV to asymptomatic subjects. That's what you will see. But you know, IPV is available now, fractional IPV is available. Therefore, you should be giving it and not the OPV. If it is available, IPV. Remember this. Don't give OPV to contacts of patients who are also to the patient himself. MMR. Okay, go ahead.
MMR at 9 months, 15 months, and 5 years in asymptomatic, and for symptomatic, if CD count is more than 15%. Hepatitis B in asymptomatic at 0, 1, and 6 months, and in symptomatic, 4 doses, double dose, check for seroconversion, and give regular boosters.
1 minute here, Lasima. The hepatitis B alone, they can ask you very specifically what it is. You have to give it double dose at 0, 1, and 6 months. We are giving it 0, 6 weeks, and 14 weeks. And that's what we are doing. But it would be better if you give it 6 months. There's a star there which will come up later. Even for mothers who are hepatitis B positive at 9 months, we are supposed to check for seroconversion. If seroconversion has not occurred, you are supposed to repeat the whole vaccine once more. If again you check, if again second check it is again negative, then you don't give a third dose, third series. That's how it is normally done. Okay.
For both symptomatic and asymptomatic, as per routine schedule at 6, 10, 14 weeks, and 12 to 18 months. Pneumococcal vaccine, PCV and PPSV 23. PCV in both symptomatic and asymptomatic as per routine schedule at 6, 10, and 14 weeks, and 12 to 15 months. PPSV 23, 1 dose 8 weeks after PCV, second dose 5 years after the first dose, but not more than 2 doses.
Why don't you give more than 2 doses? Because it causes the serum value becomes the antibody level goes down if you give a third dose. Okay.
Inactivated influenza vaccine in both asymptomatic and symptomatic as per routine schedule beginning at 6 months, revaccination every year.
That's the most important thing in immunosuppressed patient. Inactivated flu vaccine will have to be given every year. Okay, now we wouldn't change. I would read the first sentence. In rotavirus, for both asymptomatic and symptomatic, insufficient data to recommend to be given as per ACIP and WHO recommendation in asymptomatic. Okay, insufficient data to recommend to be given as per WHO recommendation in asymptomatic. Okay, symptomatic, there's insufficient data. Hepatitis A, can you carry on? Has it changed?
Hepatitis A vaccine, yes, sir.
Yeah.
Hepatitis A vaccine inactivated only for asymptomatic. For symptomatic, check for seroconversion boosters if needed. Varicella vaccine in asymptomatic, 2 doses at 4 to 12 weeks interval. Use single antigen vaccine. MMR in HIV infected children have not been studied. In symptomatic, if CD4 count is more than or equal to 15% for less than 5 years, for more than or equal to 6 months. CD4 count should be more than 2000 per millimeter cube.
200,
For
I
more
think.
than
It's
or
not
equal to
2000,
6 months.
200, isn't it?
200, sir.
Yeah.
2 doses at 4 to 12 weeks apart.
Okay.
Typhoid conjugate vaccine for both asymptomatic and symptomatic as per routine schedule. HPV as per routine schedule of 3 doses at 0, 2 and 6 months starting at 9 years of age.
Yeah, you always give the 3-dose schedule in HPV. Normally, you give 2 doses, 9 to 15 months, and then above that, I think you give 3 doses. Here's the other way around. Therefore, that's only difference. You must know only the difference. Remember here, varicella vaccine is a live vaccine, but very important to give. So is MMR. Therefore, you look at symptomatic, asymptomatic is the basis by which you change the vaccine in that time. Human papilloma viruses, I mean, I would read out to you. That's the next one. 9 to 14 years, 4-valent recommend 2-dose series. 9 to 14, you give only normal children. 9 to 14, you give only 2 doses. Minimum interval of 6 months. For 15 to 45 years, you give 3 doses. Now, what in immunosuppressed children, all children above 9 years, you give 3 doses. There's no business of 2 doses. When we discuss human papillomavirus vaccine, we said there is a move to give only single dose. WHO is moving towards that. Something else I wanted to tell you. What was it? Varicella vaccine, typhoid, HPV. I think this is the point which I wanted to make. This ACIP is American Committee of Immunization Practices, I think. ACVIP is the Indian one. Therefore, they are quoting ACIP for the recommendations. All right. Now,
Specific immunodeficiency,
this
HIV or AIDS.
This is from Nelson. Just read what I have highlighted alone.
Contraindicate.
No, contraindicate, no need. Specific immunodeficiency, risk-specific recommended vaccine. Yeah.
Risk-specific recommended vaccines, pneumococcal vaccine, PPSV 23 should be given beginning at the 2 years of age. MCV series beginning in infancy. Hepatitis B vaccine. Consider influenza
Hib.
if not administered in infancy.
So what it means is that remember that meningococcal vaccine is something which we normally don't give. Immunosuppressed patients is available. Quadrivalent vaccine, I think, is available in this one. Therefore, please remember to give it, okay? And PPSV 23 is polysaccharide pneumococcal vaccine. That is given at 23, and it is given at the age of 2 years only, because below 2 years is not effective. There should be a minimum interval of 8 weeks from the last conjugate vaccine, and it's given one booster at 5 years. After that, you can't repeat it. And here they have said HIV, they have said rotavirus is recommended. That's the American, okay? Okay, now comes the most important thing. I want to ask you, this question to you. You see many patients in the hospital who come to you with wheezing and all that, and you give steroids. If they are due for vaccine, what do you advise them? 8-month-old child comes to you with acute wheezing. You give prednisolone 2 milligram per kg for 3 days, taper it over the next 3 or 4 days. What's the advice regarding vaccination? Gopika, can you answer? Gopika is there? Hello?
No, sir.
Gopika logged in, said hello, and then she went away. What about Mohsen? Mohsen didn't come.
No, sir.
What happened? Is he post duty or something? Okay, everybody should attend. Otherwise, there should be a
He
reason
got
for absence.
PSC posting,
Huh?
so he went to join. He got PSC posting, so he went to join for that.
He has not come back. Huh?
No, he'll come by tomorrow.
All right. Therefore, my question to you, Lasima, you can answer it. You have so many patients with wheezing. I understand that almost everybody in the ward is wheezing. Therefore, you write prednisolone 2 milligram per kg, 3 days, and then the patient is still sick. You in the ICU, you give another 3 days of prednisolone, and then you taper it. What do you do in that time? And the patient is 7-month-old and he's due for MMR at the age of 9 months. What do you do? Kill the vaccine. What do you do for kill the vaccine? What do you do for normal immunization? If the child is 1.5, say 1 year and 3 months, and is due for MMR as well as for pentavalent vaccine or DPT vaccine, what do you advise them? Has it ever crossed your mind? Has it ever crossed your mind? That's my question. Lasima, how many patients
Sir,
you have
2 weeks
discharged?
after.
Yeah. Yes.
So 4 weeks.
Loudly, please. This is recorded. You are wasting time. If you say no, you say you know. If you don't know, you just pass it off. Anybody can answer. This is a crowd of postgraduate students. Many of you have been in the
4
work for
weeks.
2 years now. Yes.
After 4 weeks.
Ashwati, what do you say? Okay, I don't want to
Ashwati
waste your
went to
time.
watch.
See, this is the reason why I say that you need not know about what you call many things in advanced states like liver transplant or kidney transplant or management of resistant nephrotic syndrome as is asked but you should know what will you do to the immunization when you give steroids to the child. Now read it. I think it will change very fast. Yeah.
Yes, sir. Children receiving oral corticosteroids in high doses, prednisolone 2 mg per kg per day for those weighing less than 10 kg, or for those weighing more than 10 kg, 20 milligram per day or it is equivalent for more than 2 weeks should not receive live virus vaccine until the steroid have been discontinued for at least 1 month. Killed vaccines are safe but may be less efficacious. Children receiving oral corticosteroids in high dose, prednisolone 2 mg per kg per day for those weighing less than 10 kg or for those weighing more than 10 kg, 20 mg per day or its equivalent for less than 2 weeks can receive live virus vaccine after discontinuation of the treatment. Children receiving oral corticosteroids in lower doses, that is less than 2 mg per kg per day for those weighing less than 10 kg or for those weighing more than 10 kg less than 20 mg per day or its equivalent, can receive live vaccines while on therapy. These doses are not immunosuppressive. Children who are receiving only maintenance physiological doses of corticosteroids can receive live viral vaccines.
All of these points are important. Therefore, I don't know why you didn't know it. See, any patient who is receiving, there are three bases on which you pay patients who you should postpone by a month. That's a huge thing. That is, children who have received more than 2 weeks of 2 milligram per kg. This happens in nephrotic syndrome. Very rarely will you give in any other condition in the ward, because 2 milligram per kg for more than 2 weeks for acute asthma you may not give. Therefore, that is very rare. What normally we give is 2 milligram per kg for less than 2 weeks. Therefore, those patients on the discontinuation, you can give the treatment. You can give live vaccine. Kill vaccine can also be given, but it may be less efficacious. But therefore, when you are discharging an asthma patient due for wheezing, you can ask them to give straight away. You ask them to come after 1 or 2 days and give the treatment. In a government hospital setup, especially now that the immunization rate in Kerala is also going down, is 1-to-1. If you trust the patient will come after 2 or 3 days, you can say, come back. Otherwise, on the time of discharge itself, you give the immunization. That's the best thing. If you have given less 2 milligram per kg, but you are not given for 14 days. Now, if you have given less than 2 milligram per kg, many times for acute asthma, they may say 1 to 2 milligram per kg. Is the dose given as during the acute attack. I would prefer to give the higher dose, but if some pediatrician is giving only 1 milligram, you can give the vaccine while he is on treatment. Now, the point here is that you should understand that giving during the diseases, that your acceptance goes up. But the problem of giving it, any problem, they will add, if the child becomes more sick or child develops fever, the parents will attribute it for you to have given the vaccine during an illness. We will discuss it later. Now, there is a feeling if the patient has got Addison's disease or something and he's on maintenance physiological congenital adrenal hyperplasia, actually the maintenance physiological dose are much, much, much lower than the therapeutic doses. Therefore, he can receive all live viral vaccine. Okay, continue. Can you read it? Has it changed? I'll read the first sentence. Children on alternate day therapy, inhaled or topical therapy may be safely and effectively given the age-appropriate vaccines. Hello, has it changed for you?
Low or moderate dose of
Loudly.
systemic corticosteroid or locally administered corticosteroid in children who have a disease. Example, systemic lupus erythematosus, that in itself is considered to suppress the immune response, should not receive live RS vaccine during therapy, except in special circumstances during which the potential benefit of protection and the risk of adverse reaction are weighed.
When do you give alternate day therapy, Faisal? When do you give alternate day therapy? And why do you give it? Nasima, when do you give alternate day therapy? Hello? Nasima, you're there?
Sir, hello, sir. Sir, the call vannadairunnu. Nephrotic syndrome.
Yeah, when do you give and why do you give alternate day therapy? How do you give it?
Steroid.
Loudly, Nasima, please. See, alternate day therapy is given when long-term maintenance is required. You want to give the single dose alternate day therapy is given early morning to mimic the circadian rhythm of the steroids so that the inhibition of a hypothalamic called steroid axis is not much. Therefore, to reduce the inhibition, you may give, it's not as effective as multiple doses, but it sometimes works for maintenance especially. Therefore, children on alternate day therapy may be on 10 milligram, 20 milligram, early morning, empty stomach you may give. It is considered not to be immunosuppressive. You can continue the immunization. Now, since the problem is not as simple as that, you may have a systemic lupus erythematosus, which itself is immunosuppressed patient. Even if you give low dose, the patient will have to be considered as immunosuppressed, and live vaccine may have to be put. Therefore, it is a complicated decision in that. And it's not only, this one is a question of anti. Many children now receive methotrexate, except, for example, patients with rheumatoid arthritis, etc. Children receiving methotrexate as a dosage less than 0.4 milligram per kg, azathioprine as a dose, or sex mercaptopurine are not immunosuppressed and can receive all vaccine. If you are good enough to remember the dose, it's okay. Otherwise, you can simply remember methotrexate. The patients on methotrexate is dosage dependent. Whether you consider him as immuno. Similarly, the oral prednisolone, it is dosage dependent and duration dependent. Remember this carefully. Prednisolone is very, very important to remember. When can you vaccinate? If you have given 2 milligram per kg for 14 days, after 1 month only you can vaccinate. Otherwise, you can vaccinate at discharge. Certain other times you can vaccinate during the illness itself. Okay. Now we have something called biological modifying drugs. I'll read the first line, second onwards you can read. The biological response modifying drugs target different components of the immune system, causing varying degrees of immunosuppression and can last for weeks to several months. Now, biological suppression is now being given for in rheumatology very much, and they are very, very costly. Monoclonal antibody inhibition, etc. And they are now being considered even in severe asthma. Now, can you read the rest of it? Has the slide changed for you?
Inactivated
Inactivated
vaccine should be
Yeah, read it. Ashwati, read.
Gopika, sir.
Yeah, Gopika. Where were you?
Inactivated vaccine.
I was looking for you. You were not to be found. Okay. Gopika, you
Inactivated
read.
vaccine should be
Yeah.
preferably administered at least 2 weeks before the initiation of biologics. Live attenuated vaccines are generally contraindicated during and for weeks to months following discontinuation of the biological response modifying drugs. They should be administered at least 4 weeks before the initiation of therapy. Inactivated vaccines, including inactivated influenza virus vaccine, should be administered as per the immunization schedule and should not be withheld.
Therefore, influenza vaccine, they require more than the normal child. Okay, live vaccine, remember, this is very, very important. If you have a splenectomy, how early should you vaccinate it? We have discussed this early, 2 weeks. If a surgeon is going to do a splenectomy for a congenital spherocytosis, vaccinate him 2 weeks before. But if he does a splenectomy for a road traffic accident with splenic rupture, nowadays they do partial splenectomy. Previously, it was total splenectomy. You may have to give it after the patient has undergone splenectomy, and it's a risk factor. Therefore, the moment the patient says, I am going to start biological because this rheumatoid arthritis not responding to methotrexate, the very costly medicine, I'm going to start, the first thing you should say is, doctor, let me give him the varicella vaccine and wait for 4 weeks. Nothing will happen if steroids are, normally it is 4 weeks. Now read now, I changed the slide.
The interval between the cessation of BRM therapy and safe administration of live vaccines has not been established and is likely to vary by agent. Generally, live vaccines may be administered 3 months after cessation of the BRM therapy. However, the recommendations following rituximab therapy is different. Any vaccine history prior to rituximab therapy should be disregarded. Complete re-immunization should be done. Once B cell and IgG levels have recovered, immunization should be recommenced, which is generally 6 months after cessation of the rituximab therapy.
Remember this, rituximab is now being used increasingly even in chronic ITP, I think, even many other conditions. Therefore, normally the person who, if you go to RCC, I don't know whether you're having posting in RCC, you should go there. They have a immunization in patients undergoing chemotherapy. They have a schedule there. They actually, Dr. Priya sent it to me. I want to look at it again. Therefore, this is very important. Among all the things, the most important, rituximab is very important because it acts on the cell-mediated immunity at a level at which almost it suppresses completely. Therefore, generally, live vaccine may be administered 3 months after BRM therapy, biological response modifying drugs. But any vaccine, rituximab, if you give, you should redo the whole thing again from the beginning, and it should be completed started only after 6 months. Okay. 1 minute. Okay. Has it changed for you?
Yes, sir.
Yeah.
Biological response modifying drugs in utero exposure to BRMs. Concerns exist regarding immunosuppression in infants exposed in utero to maternally administered BRMs, as detectable drug concentrations may be present for many months following delivery. For such infants, live vaccine should be avoided for 12 months after the last maternal dose during pregnancy. BCG, OPV, and MMR or MR should be avoided in the first year of life. The safety of rotavirus vaccines in such infants is debatable and hence may be avoided. All inactivated vaccines should be administered according routine schedule. Immune response during the first few months may be suboptimal depending on the monoclonal used and the gestation period during which it is administered.
See, remember one thing here. See, immunosuppression, if the mother was given chemotherapy, is unlikely that if the lady was given chemotherapy, is unlikely that she will then become pregnant. But BRM, monoclonal antibodies, they can become pregnant. Therefore, see, remember how important it is that whenever a patient comes to you for immunization, unlike the consultants, we consultants, because when we were practicing this, biological response modifying agents were hardly used. Now it is used in for many patients, and it's very, very effective. And we have rheumatologists in our hospital who would start it. Therefore, if you inadvertently give a live vaccine or something, it can have medical legal problems. Therefore, remember to ask every patient, are you on any medication when you give vaccination? Okay. Now comes to cancer and radiotherapy. Yeah.
Cancer cases on chemotherapy or radiotherapy. Influence of cancer per se on immune function is minimal and does not contribute to a major extent in inducing an immunocompromised state. Total IG concentrations, specific antibody concentration to already given vaccines are normal at the time of diagnosis, indicating that the effect of cancer on the adaptive immune system is likely to be small. However, chemotherapy for cancer causes major secondary immunodeficiency. The effects of radiotherapy on immune function are likely to be small in comparison to the chemotherapy. Vaccination requirements for cancer cases need special consideration as described below.
Okay, remember, it is not the cancer, it's the treatment. And it's the chemotherapy with a major problem, radiotherapy plus minus. Okay. Now you have to read the whole thing.
Specific recommendations for children with cancer and their family members. Live vaccines are contraindicated during and for 6 months after the end of chemotherapy. Non-live vaccines are also best given after 6 months from the end of treatment for durable immunity. Annual IIV
Inactivated influenza virus vaccine. Okay.
is the only vaccine therapy, whereas hepatitis B vaccine is recommended only for previously unimmunized children with a risk of transfusion-associated transmission. Post-treatment re-immunization or catch-up schedule largely depends on the pre-chemotherapy immunization status. In general, a booster dose of all age-appropriate vaccines should be administered. Sibling immunization should continue uninterrupted except for OPV, which needs to be substituted by the injectable vaccine. Influenza vaccine is recommended and varicella vaccine is encouraged for all contacts, including siblings or parents. OPV is contraindicated, including pulse polio doses. Siblings should receive inactivated poliovirus vaccine, and if OPV is either given by mistake or given because there is no other option, then the sibling should remain away from the index child for at least 2 weeks.
Okay, remember this, what is written here. Note it down in your mind. Sibling immunization should continue uninterrupted except for OPV, which needs to be substituted by, this for siblings they are telling. IVV and varicella and OPV is contraindicated, even including pulse polio doses. Remember this. Therefore, it is very important for you to know this. Why I'm telling you this is, the moment you say in pulse polio OPV need not be given, the message is given over to the DMO and even to others. And they do call you and say, how can you talk against the national immunization program? Because we are trying to achieve target. And how dare you say that OPV cannot be given? Please remember, tell them that in the IAP Guidebook of Immunization, theoretically as well as correctly, scientifically, OPV cannot be given. And this is enforced, that clearly written that OPV is contraindicated even to contacts in pulse polio. Before that, they have written should not be given to the patient. Don't make this mistake. Pulse polio itself, we have already discussed, is under this one, a little scanner now. Therefore, why I'm telling you this is, there's a lot of pressure isolated, and our consultants say, if they are telling give it, they will say. If the DMO is telling give it. But your primary responsibility is to your patient and to that family, and you should stand firm. I remember recently one very experienced neonatologist in a hospital, which has about 200 deliveries every month, private hospital in central Travancore. The DMO called up and said, why are you not giving hepatitis B vaccine below at birth for preterm babies? Therefore, he said below 2 kg, because we are doing the screening of the mothers, when there's hepatitis B positive, we are not giving the dose. That's how the IAP says. The DMO said, look, if you don't give, the vaccine was not available. More, standalone hepatitis B was not available in the market. But in we can't have two things in the health service they are giving. Where you are not giving in private, you have to give. Therefore, she was telling against science. But he had to give because he had to get the vaccine. Remember this. Therefore, there can be a lot of pressure to do unscientific things, especially in pulse polio, especially in OPV, especially in hepatitis B vaccination. But you can stand firm only if you know your source of information. Now, now read this, please.
Tetanus prophylaxis in wound management.
Yeah. It came back, I think.
In
Okay.
a child with cancer who is on treatment and who then gets a wound, it can be assumed that the antibody levels are inadequate. So, tetanus wound management is as follows. In a clean minor wound, TT booster regardless of immunization status. All other wounds, TT plus tetanus immunoglobulin.
Wound management in clean regardless. See, normally we look at the immunize. There is a problem in tetanus prophylaxis. What is written in the IAP, what is written by the CDC is not what is written in the WHO. This can have medical legal problems, because normally in our CDC and in the Nelson's book, tetanus in a clean wound, if you have the child is given taken 3 doses of tetanus immunization vaccines at birth, 3, not even 4, 3 doses. If the wound is below 10 years and the wound happens, you have an accident, and even if it's a road traffic accident below up to, if it's a clean wound up to 10 years, you need not take. If it is a road traffic accident and you have a very bad wound like a saliva, etc., dog bite, etc., up to 5 years, you need not take. That's what. But in WHO does not talk about it. We will be discussing it later. But whatever this 5-year, 10-year does not apply for an immunosuppressed patient. Therefore, that's what it says. Every patient, clean wound, immunization status, whatever be the immunization status, you will give a TT, and all of the wounds, you will give tetanus plus tetanus immunoglobulin. Now, let me tell you one thing. It's a fashion for patients to give immunization with tetanus, because every wound, the first thing that your parents would ask you or the public asks, TT edutho, has the TT been taken? Is there any problem in that, Gopika, giving TT more than, how many TT can you give in a lifetime? Is there any problem in giving too many tetanus toxoid?
Yes, sir.
How many TT can you give? Nasima, your child develops a small injury. It is less than 5 years after her last dose. She does not require it. Still, you are the mother. You would say, "Kuduthe kya? Let's give." Is it okay? Now, anyway, that's not the topic of discussion right now. You have to know this. Nowadays, WHO also says a man or a girl, lady, should take only 6 tetanus toxoid in her lifetime. More than 6, never. Therefore, why? Because more and more dose of TT causes more side effects and more problems. We will come to that. We will be discussing it later. Therefore, edutho TT, any wound, don't straight away ask TT. Straight away, TT, like any other medicine, should only be given after if it is indicated. What's indicated, it will come up later. Yeah, now read this. Post-exposure, chickenpox post-exposure prophylaxis. Okay.
Varicella post-exposure prophylaxis. Children exposed to varicella infection during ongoing chemotherapy should be given prophylaxis with varicella zoster immunoglobulin or intravenous immunoglobulin and or oral acyclovir. Under ideal circumstances, varicella zoster vaccine IgG levels should be assessed at the time of exposure and for children with less than protective levels. Varicella immunoglobulin should be offered with a dose of 125 units per 10 kg and 62.5 units if less than 2 kg to a maximum of 625 units by the intramuscular route, and if varicella immunoglobulin is unavailable, IVIG at 400 milligram per kg can be administered intravenously. In case both the above are unaffordable or unavailable, acyclovir at a dose of 20 milligram per kg per dose administered orally 4 times per day with a maximum daily dose of 3200 milligram, or valacyclovir at a dose of 20 milligram per kg per dose administered orally 3 times per day with a maximum daily dose of 3 grams, beginning 7 days after exposure and continuing for 7 days can be used.
Now, let me tell you one thing to you pediatricians. You know that there are many cancers which are now treatable and curable. And one of the classical ones is acute lymphatic leukemia. And these children who die in acute lymphatic leukemia don't die due to leukemia. They don't die due to chemotherapy. They die due to infections. Okay. And one of the infections by which they can die is chickenpox. Therefore, if you have a patient who has acute lymphatic leukemia, and they say they are exposed to chickenpox, the sibling is having chickenpox, it's an emergency. It's an emergency. Therefore, you should immediately contact the chemotherapy pediatrician, Priya, or somebody, offer them what is their guideline. If you are not able to do that, ask for a varicella immunoglobulin or varicella vaccine. Follow what is given here. In case you are in periphery, they are not able to afford vaccine, you have to start acyclovir. If they are not able to afford, better start acyclovir and send him to the SAT hospital. First of all, you should remember that's an emergency. Okay. Now, it's an unimmunized child or the patient is ALL. He is on chemotherapy and the patient is exposed to measles. What will you do? In fact, measles vaccination, unlike the varicella vaccination, at the time of exposure protects the child against measles, not for mumps and rubella. Therefore, there might be a place of giving measles, but always take a second opinion. before due. What is most important for you to understand is that when a child is on chemotherapy, ALL, he may not be under the oncologist all the time. His life hinges on the pediatrician who treats him in between. And you should know that whenever he develops a fever, it's an emergency. If you do a CBC count, there's neutropenia, febrile neutropenia, finished. It's an emergency. Remember, if he is exposed to varicella, exposed to measles, emergency. Therefore, remember this, otherwise you will lose those children and there can be a problem. Now, can you read this slide, please?
Other vaccines, other non-live vaccines such as meningococcal vaccine, Japanese encephalitis vaccine, cholera vaccine, and yellow fever vaccine are not recommended by IAP for routine use in healthy children. They also have no specific role in children with cancer during or after treatment. It is recommended to consider special conditions for these vaccines as mentioned in the respective vaccination recommendations.
Yellow fever, when do you give actually? Yellow fever vaccine, is it given? Have you any idea when yellow fever vaccine is given?
Endemic areas, it is given, sir.
For Indians, where is the endemic area?
In Kerala, Trivandrum, Alappuzha.
That is Japanese encephalitis, doctor. Don't tell there is yellow fever in Kerala. Huh? Your health minister will come and shoot you.
No,
There's no
sir.
yellow fever in India, in spite of the fact that the mosquito is ready, and but no reported case of yellow fever. Now my question is, will you diagnose it when the yellow fever comes? That's a different matter. I don't want to say. It's surprisingly it is not there in India and most of the countries. It's only in African countries. Therefore, if you go to African countries, it's a must to take the yellow fever vaccine. And I think it is 14 days before travel or something. I'm not sure. Therefore, they may not. Therefore, but if you are on chemotherapy, what will you do? Live vaccine are contraindicated. Therefore, you will have to tell them, can't you postpone your journey? If it is not possible, you'll have to take it in writing and give the yellow fever vaccine. But I would advise you very strongly, nobody will come to you because these are all given by experts, travel experts, who would tell them exactly what to do. They remember, yellow fever vaccine is not routinely given at all. It's only given when you travel to these places. But you can't cancel it because you can't arrive there without the vaccination. No. Now, this is a huge table. I generally don't like you to. We have already received, we have already thought of HIV. HIV, we said symptomatic, asymptomatic. Here, this is very important table, contains lots and lots of information. Recommendation child who has received chemotherapy, whether you can give the vaccine during chemotherapy, in a child who is previously unimmunized, children who have completed immunization at the end of chemotherapy. Therefore, there are two major here: during chemotherapy, after the end of chemotherapy, and that depends whether the patient was previously unimmunized or complete immunization. Now, I would ask Ashwati to read from the parallel. BCG, start reading now. It's very important. Hello, can you read it?
Ashwati is in the ward, sir.
Okay, then you read. By turn, you attend the program. What happened? There was a call in the ward?
Yes, sir. One patient in Karthik sir's OPD. She has to inform reports to Karthik sir.
Okay. Now, can I ask you one question? Now, Gopika, you wanted 7 p.m. or 3 p.m. class?
7 p.m.
No. Because the attendance is very low. I find that if I make it at 7 p.m., it's not that easy for me. It will be only on Tuesday and Thursdays. We can try it out. This type of interference will not be there. I find it very, very annoying that I take the class and 90% of you are not there. You are not able to attend. I don't blame you for that. But 7 p.m. you should be. At least 2 days a week you should be able to attend 2 hours in the evening. Are you ready for that or not? Because the boys, I think, are happy about it. Gopika is also, Ashwati is also happy about 7 o'clock. Lasima is not. What about you?
Sir, I don't know because my kid is also at home, so she will not allow me to go to another room and sit.
Okay, but you don't want. I don't know what to do. Okay, now read it now.
We
BCG
can
only.
try at least. Sir, for 1 week, we can try.
All right. Okay, because anyway, please realize one thing. I am putting these on the this one, what you call YouTube. I will download. I take a lot of effort to put it on the YouTube. I spend money also on that. And you please go through it. When I come back with the MCQs, you should be able to answer. Remember, these are questions which you are going to be asked. You are going to be, they are going to start a chemotherapy unit in a PRS hospital. Naturally, immunization in chemotherapy will become important, not just for your exam. Okay, read BCG. Read horizontally. Okay.
BCG, during chemotherapy, it is not recommended. Contact vaccinations are not discouraged. Contact vaccination not discouraged. After end of chemotherapy, for previously unimmunized child, single dose BCG at 6 months after completion of chemotherapy. And for children with completed immunization, it is not recommended in previously immunized child with visible BCG scar.
This is a very important
OPV.
point. A very important point that chemotherapy does immunosuppression. Even then, BCG is not recommended. Remember this, okay? With the visible BCG scar. Okay, okay. Normally, remember this, Gopika, normally we don't repeat the BCG even if the BCG scar is not there, normally. But in immunosuppressed patient, if the BCG scar is not there, you will do it again, even if it is immunized. Okay, OPV.
OPV is not recommended. Contact vaccinations not recommended during the chemotherapy. And after end of chemotherapy, IPV is preferred when unavailable. 3 doses of bovine OPV 1 month apart. Maximum age is 5 years. And with children with completed immunization, IPV is preferred when unavailable. 2 doses of bovine OPV 1 month apart. Maximum age is 5 years.
Gopika, if my student Pratap, my student Pratap, who is WHO consultant for polio, he has just retired, listens to what you read just now, he will faint. What is BOPV?
Sir. Sir, bivalent, sir.
Bivalent OPV. If a pediatrician who's going to get you DCH is reading it as bovine OPV, my God.
No, sir. Sorry, sir.
Bivalent OPV, slip of the tongue, I know that. Remember that. Remember OPV is not recommended even for contact. Remember that during chemotherapy, if a patient says the youngest the patient, unfortunately, the elder one is having leukemia on treatment, immediately you should tell the relatives never take OPV. Your vaccination, don't take any vaccination, not only for the patient, but for the sibling without asking me. These are the hallmarks of a very good pediatrician. I'm telling you. And the relatives, especially in India, they really understand this. MMR, okay? Carry on.
MMR during chemotherapy, it is not recommended. Contact vaccinations are not discouraged. After end of chemotherapy, 2 doses of MMR 1 to 3 months apart should be given to all children after at least 6 months of completion of chemotherapy. And in children with completed immunization, 1 dose of MMR should be given to all children after at least 6 months of completion of chemotherapy.
Okay. So this is important. All vaccination which you have taken before, at least one booster you should give. And if you are not slept, OPV you cannot give even for contacts, but you can give MMR for contacts. Why? This is what's happened, Gopika, when you don't attend the class. But the problem is if I ask the people who attended the class also, they may also not answer. Ashwati, you are there? Nashudi is not there. Therefore, anybody else? Nasima, you are giving OPV to contacts of patients on chemotherapy. OPV you are not giving, but you can give MMR. Both are live vaccines. How come MMR can be given? Okay.
Sir,
Yes.
varicella.
No, don't. You have not answered my question. How come MMR vaccination is given to children? It's a live vaccine. OPV is a live vaccine. If you have a patient on chemotherapy, you tell the parents don't give OPV to the sibling, the other child. He's a 6-month-old child, no OPV, even during pulse polio. But at the same time, you can give MMR. Why?
Sir, OPV intestine goes to the intestine and cause.
Well, anybody else can answer this question? Just, I think today only we discussed it. It is because OPV is transmissible. It is transmissible from the patient whom you gave, the contact whom you gave. It may come on to the patient who immunosuppressed chemotherapy. While MMR vaccine, the vaccine does not, we are giving IM, and it does not transmit. The patient does not transmit to the immunosuppressed patient. Okay, now read varicella. All this we have told, discussed 100 times. Okay.
Varicella during chemotherapy not recommended. Contact vaccination encouraged. After end of chemotherapy, in previously unimmunized children, 2 doses of vaccine 1 to 3 months apart after 6 months of completing chemotherapy. And in children with completed immunization, 1 dose of vaccine after 6 months of completing chemotherapy.
Remember, MMR and varicella same because both are live vaccine. Varicella after 6 months of completing therapy, contact vaccination is encouraged. Okay. The MMR not discouraged, because why are you encouraging? We don't want varicella in the family. Okay. That's one which measles, mumps, and rubella does not cause as much of a problem. Whatever it is, use the word. Look at the words they are using very carefully. This is from the IAP Purple Book, and most probably they have following the CDC guidelines only. Now, live attenuated hepatitis C. I don't know whether it's available here. Live vaccines. Okay, read it.
Live attenuated hepatitis A. It is not recommended during chemotherapy. In previously unimmunized children, single dose after 6 months of completing chemotherapy. And in children with completed immunization, single dose after 6 months of completing chemotherapy.
Rotavirus.
Rotavirus, it is not recommended. Contact vaccination not discouraged. After end of chemotherapy, in previously unimmunized children, generally child outgrows the maximum permissible age, therefore not indicated. In both after completion of immunization also, it is same.
There's one thing very interesting here. The rotavirus vaccination not discouraged in contacts, while OPV is not recommended. Why? Both of them can be transmitted. But I think because OPV cause a paralysis, so while rotavirus just might cause a diarrhea, they're not discouraging it. Therefore, remember this, the only way to, when you have a patient, when I was in UK, whenever you prescribe a drug, okay, the most important thing is the most important thing is in front of the patient, you open the book and write the dose. That is encouraged everywhere in pediatrics in the Western world. Don't write from the memory. I will also tell you that you please, whenever you give such advices on chemotherapy, you first tell the doctor concerned, this is what I remember, but I'll get back to you and give me 30 minutes time. Go back, open the CDC in up to date, or have the latest IAP recommendation, open that page, read it, and then tell back. Don't make a mistake. Now, something has come up on the blue line here.
catch-up vaccination for children with cancer should be given 6 months after stoppage of chemotherapy. Exceptions are HPV and influenza vaccine. No vaccine is recommended while ongoing chemotherapy.
Is the most important thing. I think kill vaccine also they are not recommending, is it not? There's a vaccine recommendation who has received therapy. 1 minute, let me see. BCG or PVM, but they are talking all about live vaccine. Is kill vaccine also not indicated? Anyway, catch-up immunization, that's something which should be looked into. Kill vaccine during chemotherapy. Can you give or not give? If you give, there may be no side effect, but it may not be effective. That's why. Therefore, I think no vaccine is given during chemotherapy. All right. Okay, can you read anything? Something else has come up. I will read it. BCG IAP recommended upper age limit for vaccination is 5 years. Is contraindicated during ongoing chemotherapy and can only be given after 6 months of completion of chemotherapy as a single dose in a previously unimmunized child. In children with previously completed visible scar, no further dose are required. My question is, if the child is 8 years old, will you give it? No, it's not, I think. The next for HBV vaccine. In previously unimmunized started on chemotherapy, unimmunized hepatitis surface antigen negative, then is recommended to administer 4 doses of vaccine, 0, 1, 2, and 12 months at double dosage, as well as age-appropriate dose of hepatitis immunoglobulin every 3 months till there is no risk to exposure to blood products. That means they're unimmunized and he started on chemotherapy, you might be giving multiple blood transfusions. It's better to give the child 4 doses hepatitis B at double dose. That is 0, this is called the accelerated response, 0, 4 weeks, 8 weeks, and then not at 6 months, they are giving at 12 months. I don't know why. And this is not enough. This may not protect the child because you are giving so many blood products. It's better to give hepatitis immunoglobulin every 3 months. I don't know whether anybody follows these things anyway. Now comes the inactivated vaccine. Can you read it now? Has the slide changed for you?
Vaccines.
Yeah.
Hepatitis A vaccine inactivated and during chemotherapy not recommended during ongoing chemotherapy. After chemotherapy, previously unimmunized children, 2 doses 6 months apart, 6 months after stoppage of chemotherapy. And children with completed immunization, single booster dose, 6 months after stopping chemotherapy. Inactivated influenza vaccine during chemotherapy recommended single dose annually during chemotherapy. After end of chemotherapy in previously unimmunized children, not recommended routinely beyond 1 year from the end of chemotherapy. In children with completed immunization, not recommended routinely beyond 1 year from the end of chemotherapy. Pneumococcal vaccine not recommended during ongoing chemotherapy. After end of chemotherapy in previously unimmunized children, age less than 1 year, 2 doses of PCV 13.
Doctor, just stop it. This is the recommendation for normal children also. When you catch up immunization, there's a dose. There's no need to read through it. Therefore, it is previously unimmunized children, you will have to give the full doses. You start after 6 months after the stoppage of chemotherapy. Okay. And if it is already complete, all immunized children, you may have to give a single dose after 6 months of booster, PCV. And again, typhoid, these are all killed vaccine. Therefore, the typhoid also single dose of typhoid conjugate vaccine, 6 months of that therapy and not recommended during ongoing chemotherapy. Therefore, this is almost pattern is there in how they say about kill vaccine. Therefore, now can you read the
No IAP recommended
1
upper
minute?
age
Is this about
limit
which?
for
The
vaccine.
okay. Regarding influenza vaccine, this is, if you look at it here, this is 3 stars. Therefore, regarding the 3 stars, read it. Okay. Read it.
No IAP recommended upper age limit for vaccination. Recommended during ongoing chemotherapy and up to 1 year after completion of the treatment. Age 6 months to 9 year, 2 doses 1 month apart and then single dose every year till indicated. Age more than 7 years, single dose every year till indicated. Recommended time to vaccinate as soon as the new vaccine is released and available in market. Just before the onset of the rainy season. That is before June for most of India and before October for some of the southern states.
1 minute, doctor. See, the thing is that you must understand what it goes. Normally, when is inactivated flu vaccine recommended for children? Paris, what do you think it is? Do you recommend
6 months.
6 months to upper age, normal children?
7 7 7 year.
7 months, 7 weeks, so 7 years. What do you mean?
7 year.
Okay. I think you have not even gone along the corridor of the immunization clinic. That's what I could understand. Gopika, what do you think? Your child is how old now?
2.5.
You have
About
given flu
2.
vaccine?
Yes, sir.
You gave it 2 years?
1.5 years, sir. 6 months, 1.5 years. Then now about to give at 2.5 years.
Till what age will you give?
8 years.
WHO recommendation is up to 5 years. Okay. At least this immunization, you read carefully. You have a daughter. You have to give the right immunization for it is up to 5 years. Nothing wrong in giving 8 years, but immunization you should not give unnecessarily. When the age of 5 years, you can give. The most important indication for influenza vaccination is pregnant women, number 1. Number 2 is 6 months to 2 years. How many times I've told you, I don't know. But you can give up to 5 years. Now what it means here is that is inactivated. The most important the only vaccine in which you give continuously during chemotherapy is influenza vaccine. That's one indicator. Hepatitis B also we give. We told about it. Double dose 0, 1, 2, and 10, 12 months. Hepatitis immunoglobulin every 3 months if the patient is unimmunized. Remember that. Now here, inactivated for influenza vaccine, no IAP recommendation for upper age of limit. That is, even if a 10-year-old child comes to you with chemotherapy, you will have to give it. Okay. And you should give it up to 1 year after completion of treatment. Now, suppose the child is 3 years, he has completed treatment, you may give up to 5 years because normal children also receive up to 5 years. And the 6 to 9 years, you give 2 doses 1 month apart, starting of rainy season. But here, chemotherapy, you start throughout the. Now, the second point here, not recommended. Sorry. Not recommended routinely. 1 minute, the pointer is not coming. Anyway, not recommended routine beyond 1 year after end of chemotherapy. They put 4 stars. Read it now.
Recommendation 1 year after stoppage of chemotherapy. Not recommended routinely unless the child continues to have high-risk conditions necessitating influenza vaccination. Example, chronic cardiac, pulmonary, liver, or renal disease, diabetes, human immunodeficiency virus.
Now, one of the things you should remember is immunosuppressed. What are the patients immunosuppressed? Immediate answer from the candidate would be patients with immunological deficiency like primary, secondary, blah, blah, etc. And they would also say the patients who require flu vaccine, they would say cardiac conditions, chronic lung disease. And if you ask them cardiac conditions, does a VSD require it? Does a ASD require it? Does a patient with PDA require it? The answer to that is what you call as cyanotic heart disease all require it. Hemodynamically significant cardiac disease requires. That means if the ventricular septal defect has a cardiac failure or probably cardiomegaly, you might give it. But if he just has a murmur, that is not an indication per se to give the flu vaccine. Anyway, these are things you have to go through this very, very carefully. These are very important points. Now, regarding the read HPV vaccine, read about it. Has it changed for you?
HPV.
Yeah.
Yes, sir. HPV vaccine during chemotherapy, not recommended during ongoing chemotherapy. After end of chemotherapy, previously unimmunized children, 3 doses series 0 to 6 months for all above 9 years of age. For children with completed immunization, no recommendation for booster. Single dose may be considered in female.
Human papilloma virus, it is not an emergency to give, and therefore you can give in the usual dose. But varicella, you may give the second dose after 3 months. The human papilloma virus, is it a live vaccine or a killed vaccine? Is it a killed vaccine or a live vaccine? Gopika?
Killed.
So, okay, it is a killed vaccine. Okay. I think all this we have read anyway. Now let's go to the next slide, etc. Okay, read only what is highlighted. It's a Nelson's textbook of pediatrics. Therefore, read only what it is written.
Effectiveness of any vaccine depends on degree of immune suppression. Inactivated standard vaccines are indicated if not highly immunocompromised, but doses should be repeated after chemotherapy ends.
A very important point. We have started on leukemia. Can we give pentavalent vaccine? Yes, you can give. During chemotherapy, the child is 1.5 years, is due for a booster. Will you give it? Yes, you can give it, unless it's a highly immunosuppressed. Also, you can give inactive vaccine. But the only thing is 6 months after stopping the treatment, you might require to repeat the dose. Remember this. Live vaccine, no, you don't give it during the chemotherapy at all. You don't give it. Therefore, have a clear idea. We will come back with MCQs on this, chemotherapy, immunosuppression, etc. Now we go to a very important point. That is, remember, these are practical as well as theoretical. Many patients are now undergoing bone marrow transplant, acute myeloid leukemia, multiple myeloma, many other, even bone marrow transplant is now being done even in Calicut, in some of the private hospitals, many private hospitals. Therefore, they can ask you about immunization. Okay, read it now.
Transplant recipient hematopoietic
Loudly,
stem
doctor.
cell transplants.
That is, you have to read it loudly. Yeah.
Patient for whom some hematopoietic stem cell transplant is planned should receive all routinely recommended inactivated vaccines, including inactivated influenza vaccine, at least 2 weeks before the start of the conditioning period, when possible. Routinely recommended live virus vaccine should be administered if patient is not already immunocompromised and the interval to start of conditioning period is at least 4 weeks.
Okay. Now, what you should realize that the patient is, say, for example, acute myeloid leukemia, diagnosed myeloid leukemia, he's going in for bone marrow transplant. You, as a pediatrician, you say, stop, let me give him the inactivated vaccine. You do the marrow after 2 years, 2 weeks. Now, if he's on he's not on continuous steroids, he has not received steroids for 4 weeks. He has received steroids only less than 2 milligram per kg, and it is not immunosuppressant. You can give the live virus also, vaccine also, and start the bone marrow transplant after 4 weeks. This is what it means. Therefore, 4 weeks for live virus, but live virus vaccine is difficult to give because if the patient may already be on chemotherapy or something else. And if inactivated vaccine, you should give 2 weeks before. This is true about splenectomy also. You ask the surgeon to wait for 2 weeks if it is possible. Okay, read the rest, third line, 3rd and 3.
By vaccinating the non-immune patient before hematopoietic stem cell transplant,
Paris,
some
it's not getting,
protection-
I can hardly hear you, therefore it won't get recorded. Please shout loudly. Okay.
Some protection likely will persist in the months after transplant. However, recipient of some stem cell transplants are likely the unimmunized, as they have lost all memory response during the marrow ablation.
This is a very important point. Therefore, by vaccinating non-immune recipients, some protection will last. But once he receives a bone marrow transplant, the memory cells are all gone. Therefore, he is like an unimmunized patient. Remember this very, very carefully. Okay. Now, after, so far we said that when you go for bone marrow transplant, we said as a pediatrician, we'll say, wait, we'll give the inactivated vaccine if something is missing 2 weeks before. And if it is live vaccine, he's not already immunosuppressed, we would like to give it for 4 weeks before. Now, what happens after the bone transplant? Read this, please. Can you
3
read?
doses of tetanus or diphtheria containing vaccine should be administered 6 months after the hematopoietic stem cell transplantation. For patients aged more than or equal to 7 years, a dose of Tdap vaccine may be administered, followed by 2 doses of Td vaccine. 3 doses of IPV, Haemophilus influenza type B, hepatitis B vaccine should be administered 6 to 12 months after the hematopoietic stem cell transplantation. If a post-vaccination hepatitis B surface antibody concentration of more than or equal to 10 international units per ml is not attained, hepatitis B vaccine course can be repeated. 3 doses of pneumococcal conjugate vaccine should be administered to adults and children starting at age 3 to 6 months after the HSCT. At 12 months after the stem cell transplantation, 1 dose of pneumococcal polysaccharide vaccine 23 should be given provided the patient does not have chronic graft versus host disease. For patients with chronic graft versus host disease, a 4th dose of PCV can be given at 12 months after the stem cell transplantation.
Okay, now these every point is very, very important in this case. You treat him as unimmunized, completely unimmunized child. Therefore, you would like to give him all the vaccines. How we know that? All the killed vaccine is given in 3 doses, 0, 6 weeks, 6 months. Okay, remember this. This is the best immunization schedule. We will come to that later. After 6 months, after the 6 to 12 months, they have written normally 6 months. In hepatitis B, immunosuppress is better to check for the anti-HBs concentration because we have a very good correlate and it is very well available in the lab. Now, Gopika, if it is negative, if you give 3 doses, 6 months, 0, 6 months, and 0, 6 weeks, and 6 months, you check it after 1 year, 9 months after the first dose, it is less than 10. What will you do? You repeat the dose. And then you again check the level after 1 year or 6 months. Suppose it's again low, what will you do, Gopika? You are given 2 doses series of hepatitis B. Still the patient is not having adequate antibody titer. What will you do? Lasima. Absolute silence. Please don't waste time. If you don't know, you say don't know. Do you know or no? Can you hear me?
No, sir. I don't know.
Hello, Faris. I can't hear.
No, sir.
Yeah, what will you do if you have a given 2 dose hepatitis B courses and still the surface antigen is negative? Now you see, you come here as a, no, it's called a non-responder. It can happen even to normal persons. Now you come here, they do the hepatitis B antibody titer as a doctor. If it is more than 10, they say you're protected, you're into the ward. You're not protected, they will give you hepatitis B and check the titer. So suppose a healthcare worker or similarly a patient, even immunosuppressed patient is less than 10 after 2 doses. Here is written after 1 series, you repeat 1 more. Hepatitis B course can be repeated once. It cannot be repeated more than once. Otherwise, 2 courses can be given. Even after second course, if it is less than 10, what you tell the patient is any injury, you will have to take hepatitis B immunoglobulin. That's the answer to it, okay? Remember this. All right, all these points are very important. You have to think about it. After the, what else? Can you read it? Has it changed?
Yes, sir.
Read
1
it
dose
first.
of influenza
Yeah.
should be administered annually to person aged more than or equal to 6 months, starting 6 months after a stem cell transplant, and starting 4 months after if there is a community outbreak of influenza. For children aged 6 months to 8 years of age who are receiving influenza vaccine for the first time, 2 doses should be administered. Influenza vaccine is recommended annually lifelong
Very
in
important
post-transplant
point.
recipient.
Annually, lifelong. I didn't. I should have underlined it. I would do that later. You see, lifelong. So if you have a patient who has bone marrow transplant, ask him, are you receiving influenza vaccine lifelong? Okay, that's very important. All right, go ahead.
2 doses. 2 doses of meningococcal conjugate vaccine should be administered 6 to 12 months after stem cell transplant if the risk of meningococcal disease is high. 3 doses of human papilloma virus vaccine 6 months to 12 months after stem cell transplant for female patient aged 11 to 26 years may be considered. Live vaccines should not be administered to stem cell transplant patient with active graft versus host disease or ongoing immunosuppression. MMR and varicella vaccine should be administered 24 months after transplantation of if the hematocrit recipient is presumed to
I
be
think they missed the HS in that.
immunocompromised.
Is presumed to be
It's-
immunocompetent. Therefore, live vaccine, 24 months. They say 24 months, not 12. I thought it was 6 months. I don't know why they say 24 months after the but this one, MMR and varicella should be administered because they are important. Here, the most important point which I got is flu vaccine lifelong. That is a very important point. There are many patients walking about. Some of your relatives may be having. The bone marrow transplant is a curative treatment. It's curative for myeloid leukemia, curative for multiple myeloma, curative for many other diseases. And how will it look if they die of flu rather than due to the complication? Okay. Therefore, they have written a schedule here. And the most important thing, you can go through it. They see, I would just, if I ask you to read too much, time will go. But what I have underlined, these are all about how many months after, 6 to 12 months after they are telling you start immunization. Better start at 6 months. PCV 13, start 3 to 6 months. Remember, why they say 3 to 6 months? Because pneumococcal is one of the most important complications. Now, this is the standard of catch-up immunization. I would not go into it. Rotavirus, they say, is contraindicated after post-HCT. Okay. Now, if you read it, the normal killed vaccine is at 0, 1, and 6 months. But here, why 0, 1, and 6 months? This gives the longest long-term immunity. Why in the hell then they give hip vaccine at 4 weeks interval, HBV at 4 weeks interval, IPV at 4 weeks interval? What's the problem? Why there's a difference in the here PCV 13 also at 4 weeks interval? IPV at 3 days for 4 weeks interval. Gopika, can you tell me? Nobody's opening the mouth, or they are not hearing my. How many people are there? Who are there now? Ashwati has come back.
Sir, I didn't hear the question, sir.
Why you slept off or what? The question here is, you're seeing a chart on the table. This is schedule. When a patient comes back to you after immunization, suddenly you may get a call. Doctor, I'm sending you a patient, is a bone marrow transplant patient, and we want to write the schedule. Or you may be asked, what's the schedule which we write? You can open, the best thing to do is open the purple book or CDC guideline and just write it down. But in the exam, you can't do it. They will ask you these questions. You start 6 to 12 months after. PCV 13 alone, you start 3 to 6 months because it's an emergency. Rotavirus, look at the schedule here. DPT 0, 1, and 6 months. All others are at 4 weeks, 3 doses, 4 weeks interval. And here also 3 doses, 4 weeks interval. Why is it that? See, you must use your common sense along with that. You see, we want diphtheria, pertussis, tetanus, long-term immunity. Therefore, we like to give only if you give at this interval. If the first dose, second dose, and the last dose should at least be 8 weeks. The best schedule is 0, 1, and 6 months. That's why you give it here. Then why not in HBV in a hip? See, hip, the maximum protection you need is up to 5 years. And you need it immediately because you can get a pneumonia, you can get a what you call hepatitis B immediately. Therefore, you require immediate protection is required. Therefore, you give 3 doses 4 weeks apart. But long-term protection will not be good. But you are not very concerned to have protection above 5 years. Even hepatitis B, I'm a little suspicious why they gave at this dose. And they say, we want to get the hepatitis B fast because after the bone marrow transplant, you might give him blood and everything. That might be the reason. Okay, that is it. Now, PCV 13, they are given regardless of age. And I have given it a red mark. Why is it so? Normally for children, what is the upper age of giving PCV? Beyond which age you won't give PCV? Pneumococcal vaccine, normal children, highest age. Gopika, unimmunized child comes to you 3 years. Will you give him? Pneumococcal vaccine. Lysema. Hello, nobody is there or everybody is silent fall. If you don't know, please answer don't know. Paris, can you hear me, please?
Yes, sir.
Hello, why you're not answering? You see, we are wasting time because you're not answering. If you don't know, say don't know.
Don't know, sir.
Huh? Can you hear? I don't know.
5 years.
What's it? Up to 5 years, pneumococcal vaccine. What about the Hib? Hepatitis, Hib vaccine, Haemophilus influenza. Also 5 years? Just check up and tell me.
5 years.
5 years, okay. But remember that when you give for a post-transplant patient, even if the patient is 8 years or 9 years, you will still give pneumococcal vaccine. These are very important points which you should know. Okay, please answer don't know the moment I ask you, because otherwise is unnecessarily we are wasting time and it will be a time limit on this. Okay, now this is yeah, but there are some other vaccines also. I would but this is what you call as post bone marrow transplant. This inactivated, I think this one, influenza vaccine. There's nothing much. MMR is given 24 months later. Live vaccine, they try to give it only after 24 months because probably by that time only it will recover. Inactivated, you might be able to give 6 months. Varicella, hepatitis C, serology is required. Meningococcal vaccine, for people with ongoing risk of invasive meningococcal disease, it might be required. JE vaccine useful only if indicated. Therefore, these are things which you should know. And rabies, of course, you have to give use indicated, ID not recommended. ID means what? Intradermal is not recommended. See, now they say very clearly intradermal is as effective as what you give intramuscular in rabies vaccination. Dendritic cells are present in the intradermal area, etc. They do not advise intradermal for immunosuppressed patient because it's a life and death issue. Why do you think it is the reason? The reason I think is because no study has been done in immunocompromised patients. That might be the reason why they are telling it's is not to be given intradermal. And MMRV means there is it's not available in India. Measles, mumps, rubella, and varicella combination. As far as I know, it's not available. It's not given in this schedule. So go through this table very carefully. We will go. This is not only this. We have the question of immunization in primary immunodeficiency. So far, we were considering immunodeficiency in giving steroids or given immunosuppressive treatment, biologics, etc. There is a primary immunodeficiency. Can you read it? Gopika, can you read it? Lasima, please go ahead. Hello.
The B lymphocyte defects,
Yeah.
X-linked A gamma globulinemia, all vaccines are contraindicated.
Live vaccines.
All live vaccines are contraindicated. Then common variable immunodeficiency also, all live vaccines are contraindicated.
Okay, remember that in excellent hemoglobin annually inactivated influenza vaccines, only vaccine administered routinely to patients receiving IVIG replacement therapy. Remember here, there's one problem with immunodeficiency. What is that? He's lifelong immunodeficient. And in A gamma globulinemia, Bruton's disease, as we call it, is lifelong administration of IVIG. Therefore, you cannot give, therefore, all live vaccines, it will get affected, okay? B lymphocyte deficiency, yeah.
Selective IgA deficiency, OPV is contraindicated. IgG subclass deficiency, no vaccines are contraindicated. Comments: all inactivated and live virus vaccines on the standard annual schedules are safe, likely are effective, and should be administered. Polysaccharide vaccine, pneumococcal polysaccharide vaccine 23 should be administered beginning at 2 years of age.
Therefore, IgA's subclass deficiency is supposed to be not that uncommon. And you are not supposed to give immunoglobulins for treatment. You give immunoglobulins IVIG treatment only for agammaglobulinemia. IgG subclass, you may, why you don't give? Because IgA is not there. When you give immunoglobulin which contains IgA will be taken up as a foreign protein and it may produce an anaphylaxis. Okay. Read the T lymphocyte defects.
T lymphocyte defects, severe combined immunodeficiency. All live viral and bacterial vaccines are contraindicated. Then all inactivated vaccines are ineffective. Annual inactivated influenza vaccine is the only vaccine administered routinely to patients receiving IG replacement therapy if there is some residual antibody producing capacity. Complete Dijor syndrome, also the same thing. Then partial Dijor syndrome, Viscott-Aldrich syndrome, and hyper IgM syndrome, ataxia telangiectasia. All live viral and bacterial vaccines are contraindicated. All inactivated vaccines are safe and may be effective depending on the degree of immune defect. Age-appropriate vaccine should be administered. MMR and varicella vaccine, not MMRV, can be considered for those with more than or equal to 500 CD3 plus T lymphocyte per millimeter cube, more than or equal to 200 CD8 plus T lymphocytes per millimeter cube, and normal mitogen response.
I don't understand when partial Dijot syndrome, Viscott-Aldrich, hyper IgM, vaccines that are contraindicated, they have written all live viral and bacterial vaccines. And in the comments, they have written all inactivated vaccines are safe and may be effective depending on the degree of the immune defect. What does it mean? And if it is contraindicated, this is what happens in the purple book. They will immediately write a wrong statement, okay? This is slide 35. Wrong statement, okay, in table. Now remember this, very important. T lymphocyte deficiency, naturally live viral and bacterial vaccines are contraindicated. But the only vaccine that is effective is this one. Now, what surprised me here is the common variable deficiency. It's supposed to be common, it's supposed to be variable. Therefore, whether you will not give any live vaccine is difficult to understand. That is one thing. You may have to immunize him, but they are telling don't give. It was very important to remember. Severe combined immunodeficiency, all live viral and bacterial vaccines are contraindicated. Now, how will you suspect combined immunodeficiency? Severe combined immunodeficiency is when you do the total count, you may find the neutrophils 95% or 90% with hardly any lymphocytes. Then you will have to think in newborn period, if that happens, you have to think about it. And one of the reasons you should not give BCG. But the problem is we give BCG at birth, therefore all combined immunodeficiency are likely to receive the BCG. And if you are appearing for MRCP exam, Gopakumar is there. Nowadays, BCG is not given at birth in UK. It is given at 28 days because they are doing screening for immunodeficiency. And only if the immunodeficiency is not there for patients who are at high risk, not the local population, but Asian risk, etc., they give the vaccination. For all this, equally, you will have to go through it intelligently. Now, selective IgA deficiency, they are written all inactivated live vaccines on the standard annual immunization safe. Remember this, IgA deficiency is very common. Not that common, I mean, it is present. It doesn't produce serious life-threatening infection, but causes recurrent respiratory infections. For these patients, vaccination is more important than the normal children. What is this? Vaccination of persons with primary. I think the previous one was B lymphocytes, the purple book. This is from Nelson's test book of pediatrics. Therefore, we are looking at what it is. And just read what is highlighted alone. B lymphocyte, this one, contraindicated
B
vaccine.
lymphocyte
Yeah.
contraindicated vaccine is OPV.
No,
Specific
you
recommended
read
vaccines are
horizontally. Please read horizontally. Yeah.
annual inactivated influenza vaccine is the only vaccine given to patients receiving IG therapy. Routine inactivated vaccines can be given if not receiving IVIG. Pneumococcal Hib vaccine in children 12 to 59 months of age.
Okay, therefore the problem is they are telling that if you are not receiving IVIG, you can give, but the patient will receive IVIG, is it not? The patient has to receive IVIG. I don't know how he says the patient is not receiving, because lifelong he will receive it. And here B lymphocyte X fully vaccine admits routinely patients IVIG. And therefore that's here they have written B lymphocyte, the same. Therefore, you can't give any other vaccine. But I don't understand, because you have to give pneumococcal. If it's effective, it's effective. Okay, now read the highlight down. Less severe antibody.
Less severe antibody deficiencies. Example, selective IgA deficiency and IgG subclass deficiency. Then OPV, BCG, yellow fever vaccine are contraindicated. Other live vaccines appear to be safe.
What are the other live vaccines? That is, I think, MMR, is it not? MMR. Yeah, that appears to be safe. What does this book say? We are talking about less severe B lymphocyte deficiency.
Subclass deficiency.
Here they have written vaccines that are contraindicated, all live vaccines, while Nelson says other live vaccines appear to be safe. Okay, see, look at the subtle difference of what they are telling. And what about the effectiveness and comments?
All vaccines are probably effective. Immune response may be attenuated.
Or in other words, what they say is when there's partial antibody deficiency, like selective IgG subclass, they are advising every vaccine other than yellow fever, OPV, and BCG. Okay, and all vaccines are probably effective, but they may be less effective than normal patients. And this is slightly different from what is given in the purple book. But don't you think you should be vaccinating them? Because therefore, that's a very difficult decision you will have to take combined. When you do immunoglobulin, surprisingly, I don't find IgA deficiency very common here. In the Gulf, I had seen patients like that. And in those patients, blood transfusion is a dangerous thing, because IgA is a foreign protein for them. You give a blood with antibodies with antigens which contain IgA, it might produce an anaphylaxis. I think there's not much difference. Only thing is, you can go through this carefully and see, is there any difference between it and the previous one? T lymphocyte defect. I think there's not much in it. Let's go to the, now here, this is something which they have, they have not written. Clinical syndrome, okay. Now here, if you have complement deficiency, remember this, none of the vaccines are contraindicated. All inactivated live typhoid, everything can be counted. Chronic granulomatous disease is not an uncommon inherited disorder. It is often a question of gray cases in MRCP. And in live bacterial vaccines can be given, cannot be given, because they are more likely to produce. What is the live bacterial vaccine we give? Anything? We are not giving anything. Typhoid live is available, but I don't think we are giving any live bacterial vaccine. Are we? No. Phagocytic defects. Vaccines that are called, there you have viral and bacterial vaccines which are contraindicated. Therefore, if you have a Chedak-Higashi syndrome, Hipio syndrome, etc. Remember, complement deficiency, there's no contraindication. Chronic granulomatous, we will be discussing immunodeficiency. Chronic granulomatous disease and common variable immunodeficiency are important diseases to know. And here, live viral vaccines are not indicated. Okay. Now coming to in phagocytic defects, they have said that all bacterial vaccines are contraindicated. So this is from Nelson. This is from Nelson's test book. Here, all live viral and bacterial vaccines in phagocytic defect. You go all bacterial vaccines. Therefore, there's a subtle difference between Nelson and this one. I don't think it's very, very important. I think we have already touched 5 o'clock now. And we will discuss, we have 20 more slides in this. Therefore, we will discuss it on next day. For next, I will inform you the timing and the date of the next presentation.
Okay, sir.
Okay, then how do I stop the recording now? Stop share. Yeah, we stop share. And our